Spencer? We're good. All right. So I'm going to talk to you about clinical abnormal psychology, clinical psychology. How many of you have had this class already? Okay, so basically everybody's had abnormal. So this should be a review for you. All right. I sat through the practice MFT, so this is not, I'm not pulling questions directly, like I'm not doing anything unethical, but I've also structured this review to kind of encapsulate some of the things that you really might encounter on the MFT, right? So the first thing I want to go over is the classification systems. Primarily in psychology, we use the DSM-5, right? It's not the DSM-V. The DSM-5 because they switched from Roman numerals to Arabic numerals this edition because they're going to do 5.1, 5.2, 5.3 instead of DSM-4, the IV4 TR, all right, which is what they had done in the past. So just worth noting that it's an Arabic numeral instead of a Roman numeral. DSM stands for the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. It's published by the American Psychiatric Association, and it includes about 265 diagnoses. It has some things for future study, but about 265 different diagnoses. It's a standard and common language, so this is what we use to talk about mental health disorders. This is how we structure our language so that we have common language, so that if I say schizophrenia, you have a working knowledge of what that is, right? And it's commonly taught in graduate and undergraduate programs. The ICD-10, which maps onto the DSM-5, right? The number codes are the same. The ICD-10 is what we use, those number codes for billing for insurance, and it's a World Health Organization publication. So in contrast to the 265 DSM diagnoses, we've got 14,400 ICD-10 codes, including things like, you know, all kinds of medical diagnoses, like sucked into a jet engine second time, right? Like they have the craziest diagnoses you can think of. They're all included in the ICD-10. Probably if you can think of something that could horribly go wrong with you, you'll find a code for it in ICD-10. But just know that there are two different ones, but that they are intentionally aligned. The codes are intentionally aligned. So the DSM-5 is broken down into a lot of different categories, right? A lot of different classifications. We've got neurodevelopmental, schizophrenia, bipolar, anxiety. I'm not going to be able to spend time, as you might imagine, talking about every single one, right? So I'm not going to talk about, for example, the elimination disorders, which would be like enuresis and capricis, inability to hold your urine or your feces, sleep-wake disorders. So I'm not going to get into all of them, but we're going to try to like hit as broad a base as we can with as much detail as we can get this time. The first category, it was formerly called diagnoses found in childhood. And here's the thing. They may still have some holdover things from the 4th edition of the DSM on this major field test because they revise it every few years. And the last revision came around about the same time the DSM-5 came out. So recognize that they might say holdover things like diagnoses first found in childhood as opposed to neurodevelopmental disorders. But they're basically the same thing. It's just a new term. We've really incorporated a lot of this neuro language into the new DSM, which sort of medically legitimizes what we're doing, right? So neurodevelopmental disorders are going to include things like intellectual disability, formerly called mental retardation. So in intellectual disability, you have to have two key components. Does anybody remember from abnormal what those are? Low IQ and? Yeah, impaired adaptive functioning, right. So you have to have those two key components. It used to be years ago that we could just measure it on IQ, but that's not the case anymore. We have to have impaired adaptive functioning as well. We also have our communication disorders. That's where we've got stuttering, social and pragmatic communication disorder. We won't go into too much detail on those. Autism spectrum disorder we'll talk about for a little bit. So in autism spectrum disorder, what we're looking at is communication, impairments in communication. So the difficulty with a back and forth pattern of communication, right? So if I'm talking to a child who's autistic but who's very verbal, they may just go on and on and on and on and never let me get a word in edgewise, right? We don't have that back and forth in communication. It's also reflected in impairments in social interaction. So we don't see like shared attention. Like if I'm doing an assessment for autism, I can say, hey, Andrea, look, and I'll see if she looks, right? And if she doesn't look, then I move to another level where I sweep my hand through her field of vision and I point to see if she looks. But if she still doesn't look, then I'll say to the parent, have her look in any way that you can, right? And so we're looking at that. Normally we have good eye contact. Normally I can get joint attention shared, but we see impairments in those things for autism spectrum disorder. We also see stereotyped behaviors, the flapping or the peacock posturing or the rocking, or sometimes self-injury. And we often see restricted interests as well, right? So if you can think of a child who has autism that maybe maybe they have a restricted interest in trains, that's really common. Or I worked with a little boy who had a restricted interest in vacuum cleaners. And so he came in for his assessment, he would tell me every single part of a vacuum cleaner. He could tell me all the different makes and models for different vacuum cleaners. He could take a vacuum cleaner apart and put it completely back together again because that was what he was interested in. And if I didn't talk about vacuum cleaners, like when I was trying to get him to play with me, if I didn't use his interest, then I couldn't get him to engage, right? But if I could use his interest, if I could say something about a vacuum cleaner, he would engage. So we use that a lot when we're working with autistic kids. Yeah?
And Asperger's isn't a thing anymore, right? It's just all autism.
Great question. Right, autism spectrum disorder now. And Asperger's went away with the DSM-5, with the revision to the DSM. Now it's called mild autism spectrum disorder. And it was a huge, huge, huge controversy. And a lot of parents of Asperger's children and individuals who were diagnosed with Asperger's really, really rejected that because they feel like autism spectrum disorder doesn't really reflect their lived experience, right? So it is not included in this iteration of the DSM. It is commonly still used in vernacular. People use it a lot still. And so you'll hear it a lot, but it's not an official diagnosis anymore. Good question. We've also got ADHD in the neurodevelopmental disorders. ADHD, all of these are diagnoses that typically occur in childhood, right? And so with ADHD, we actually see that it moved from the symptoms had to be manifest before like age 7, and now it's before age 9 or 10. So, but still, those symptoms have to be manifest in childhood. So for ADHD, like you don't spontaneously develop ADHD as an adult. It would be a different category. We wouldn't diagnose you that way, unless. And we do ADHD evaluations here on campus in the count. Well, we did, not we, because I don't do them anymore. I teach y'all now, but we did do them for adults who are college students who maybe never have had a diagnosis of ADHD. But we have to demonstrate that those symptoms showed up early in childhood. And we do that by asking somebody who knew that person as a child and asking that person to reflect on their own childhood. And we have to have evidence, at least verbal evidence, that those symptoms began to show up before that, like the age cutoff. I think it's, yeah.
Correct me if I'm wrong, but I heard that it was kind of known from what I read that there is a difference, a gender difference in how ADHD is pronounced. For instance, boys, you get that typical hyperactivity, concentrate, whereas the girls, they're more forgetful, kind of airheaded, distracted.
So what you're talking about are two different subtypes, right? So there are actually 3 subtypes of ADHD. Who knows what they are?
Isn't it like you're like intense in the hyperactivity, low in the attention, and then like vice versa?
And then there's a combined type. So hyperactive impulsive subtype or inattentive subtype. So primarily hyperactive impulsive or primarily inattentive Or you can have a combined subtype where you exhibit symptoms in both areas: hyperactivity, impulsivity, and inattentiveness. And there are some gender differences, and girls tend to experience more inattentive subtype, and boys tend to experience more hyperactive, impulsive subtype. But I wouldn't get real hung up on that difference, because what we know, and this is going to be true across the board, there are some gender differences, but our within group variance, so within females, the within group differences is going to vary much more than the between group differences, right? So it's going to look very different from one female child to another female child, and that may not map directly onto a female child versus a male child. Does that make sense? So within group variance is greater than between group variance, and you should just know that broadly about most of the things that we talk about. Okay? So those are the 3 subtypes for ADHD. Specific learning disorder: you've got math, you've got reading, you've got writing. What we look at is an impairment in academic achievement that's discrepant from ability. And ability is typically measured by IQ measures. So, and a discrepancy between achievement and IQ. And the way we measure learning disorders is in flux right now, based on some things that have happened, legislation for special education, because primarily that's where you see it manifest, is in schools. And that's actually probably going to change again under this administration, or at least there are some indications that that might happen. So I think the IDEA information has actually been removed. IDEA is a special education law in our country that provides for individualized services for children with special needs. I think that information has been at least partially removed from the federal education website. So we don't know what's going to happen with IDEA, right? So we'll see. And then you've got motor disorders like Tourette's, tics, things like that in the neurodevelopmental category. So treatment recommendations. This is what Reagan was asking me about. We didn't cover this really explicitly so much in abnormal, at least in my class, in my section of abnormal, so I don't know what y'all's background is on this, but I've tried to include treatment recommendations for most of the broader categories. Primarily with the neurodevelopmental disorders, we're going to focus on behavioral interventions, right? So that might be ABA, applied behavioral analysis, adaptive skills training, life skills training, or adaptive functioning. So we're looking at occupational therapy there, and then behavior plans. So with a child with ADHD, a lot of times a psychologist will work with a teacher and a parent to develop a behavior plan. That might include a token economy, which is immediacy of rewards and consequences. Do y'all know what a token economy is?
Give them a star if they did good.
You give them a star if they did good, and then they save up their stars, and they can use those stars to buy a prize later on, right? That's token economy. What you do when you're working with somebody with ADHD, or you're working in a behavioral setting like this, you want to have some immediacy. So as soon as somebody does a behavior, you want to either reward that behavior if you want to increase the frequency of it, or you want to punish that behavior if you want to decrease the frequency of it, okay? And you're going to learn more about that in your learning theories section. But we want concrete, predictable rewards. And another big component for working with neurodevelopmental disorders is psychoeducation, primarily for the caregivers, making sure the caregivers understand how these disorders impact their child's development. Okay. I was doing this, I was working on this, and I was sort of all over the place. So these are not in the exact same order that they are in the DSM, but just sort of bear with me as we go through this. You need to know for sure the difference between positive symptoms and negative symptoms in schizophrenia. Who can tell me the difference? Yeah.
Positive symptoms are more of like the hallucinations and the delusions and stuff like that.
Yeah.
And the negative symptoms are things like the isolation or like social withdrawal.
Yeah.
Things like that.
So you can think of this as a baseline level of functioning, right? So a baseline level of sort of normal functioning. I have some range with regard to how I express my emotions, right? I can be happy and I can be sad. That's not flattened. So normal functioning includes that. It includes a sort of a normal level of social interaction, a normal level of speaking, right? That has some variation in tone and inflection. So if you think of a baseline level of functioning as sort of a normal level of functioning, and I recognize that the range of normal exists, right? But you can think of positive symptoms as things that are additive to that normal experience, right? So things like I see things that other people don't see, I hear things that other people don't hear, or I believe that I experience things that other people don't experience, right? So that might be a delusion of persecution, right? So I have this system of beliefs that the government is after me, and that's a delusion of persecution. So delusions and hallucinations are positive, they're additive. Things like alogia, avolition, anhedonia, flattened affect, asociality, those are reductions in sort of the normal, okay? So know the difference between positive and negative symptoms. And then there's the disorganized symptoms, the disorganized behavior, disorganized speech, and there are different subtypes for schizophrenia. And I think that's going to be sort of beyond the scope of what we need to talk about today. But know the difference between positive and negative symptoms and have a pretty good idea. Like panic attacks don't typically happen. They're not a typical symptom of schizophrenia. But delusions, hallucinations, these lists here, these are typical. Okay, so know that. When we're talking about the schizophrenia spectrum disorders, that includes other things, right? So it includes schizotypal personality disorder, schizophreniform, delusional, and schizoaffective. The way that I remember this, schizophreniform is a form of schizophrenia that's not quite as severe, right? So it doesn't meet all the diagnostic criteria. And schizoaffective, affect is emotionality, so there's a mood disorder component to schizoaffective disorder, right? And then the delusional disorder is just the presence of delusions in the absence of some of the other schizophrenia symptoms. And schizotypal personality disorder is that magical thinking that doesn't quite rise to the level of a schizophrenia diagnosis, okay? And then I put up here the diathesis stress etiology. Do you know diathesis stress? So Dr. Mason actually talked a little bit about it, and she called it the something interaction. What was it, Nicole?
It was basically a cup.
Uh-huh.
You're born with so much already.
Yep.
And depending on the environment, it can cause it to overflow or, stay at the baseline and you don't.
Mm-hmm. So it's like a biology
It's,
interaction.
yeah, I have it. It's the theory suggesting that pre-existing conditions,
Uh-huh.
Genetic characteristics, personality, may put a person at risk for developing a psychological or who is at risk.
Yeah, and I really liked the characterization of it being like a cup, and it just sort of puts you over the top, right? But that's the same thing as diathesis stress, right? So that interaction theory, person-environment interaction theory is what I think is what she called it. That is the same thing, basically, where you have a genetic predisposition, and then your environment causes symptoms to manifest or not, right? Yeah.
So theoretically, if someone has been diagnosed with schizophrenia,
Uh-huh.
and you are able to target which environmental factors were contributing to the symptoms,
Mm-hmm.
if you are somehow able to reduce or remove those environmental factors, how would that affect their schizophrenia? Like, will they have schizophrenia to have it, or will that is the symptom of this body?
So that's a really good question, right? And with schizophrenia, the thing to know is that the symptoms of schizophrenia wax and wane, right? So you have periods of really strong lucidity, times when you're really, really engaged with reality, and there are times when that reality sort of retreats. And making modifications to the environment makes a difference, but there are things that you can't adjust for, which can create, which can cause schizophrenia to manifest. So I'm going to upload into Blackboard a documentary that I showed my abnormal class, where there are two twins, and one twin manifests schizophrenia and the other twin has not. But there are so they were raised in the exact same environment, but there were stressors that were associated with birth for the young man who did develop schizophrenia. So like you can't ameliorate that, right? You can't change how much oxygen he got as he was being delivered, or how long it took for the delivery process. So a lot of times we don't know what causes. We don't know what those exact stressors are. If you can reduce symptoms that are like interpersonal stressors, then you can actually make some changes in how prominently symptoms manifest. So treatment for schizophrenia, the earlier you identify it, the earlier you receive treatment for it, the better your outcomes are likely to be. So you can impact it, but I wouldn't say that you can like resolve it. Does that make sense? This is a really convoluted answer, so I'm sorry about that. But the earlier you intervene, the better chances.
I did abnormal in the Fort Worth
Uh-huh.
center or whatever, and I think that she said that the symptoms kind of go in like a remission.
They
state,
can.
Right?
Yeah, they can. And then sometimes they can come back really powerfully.
Right.
Even if nothing else changes, right? So you can think of it as like tides on the ocean. Sometimes they're really, really strong, and sometimes they can completely go away. And I have worked with people, and so it impacts people differentially, right? So it's a spectrum for just the same way autism is a spectrum, because you can fall anywhere on the spectrum in terms of how significantly you're impacted. So I've worked with students who are diagnosed with schizophrenia who are like college students doing great, making like just really clipping along and doing great. And then I've also worked in a hospital doing psych assessments with schizophrenia, people with schizophrenia who are catatonic, right? Who are waxy catatonic, where their bodies will hold a position. You put them in a position and their bodies will hold that position. So it has a hugely differential impact, and it can come and it can go. So when we talk about treatment recommendations for schizophrenia spectrum disorders, a lot of times we're looking at medication first, right? Antipsychotic medications. And there are a couple of generations of that. And I think that's beyond the scope of what you need to know. But know that the first line of treatment is antipsychotic medications. And there are some pretty severe symptoms or side effects from some of those, like tardive dyskinesia. Do you know what that is?
It was on the quiz.
Was it?
Yeah, I didn't know.
So tardive dyskinesia is involuntary movements of the mouth. It looks like this. And it can be a side effect. Extrapyramidal side effects like water retention, weight gain, constipation, cotton mouth. Those are all some side effects from antipsychotic medications. And it's hard, right? So psychoeducation is not really up here, but it's hard for antipsychotic medication and bipolar medication, mood stabilizers. Those are the hardest ones for medication compliance, because the side effects can be really powerful, and there are cognitive distortions, like thought distortions, that don't support you continuing to take medication, right? So if you have a delusion that people are trying to control your mind and then somebody's trying to give you medicine, you don't really want to take that medicine, right? It doesn't feel honest to you. Well, I'll talk about bipolar in a minute whenever we get there. But we also look at family support and training, and CBT and mindfulness interventions can be helpful for people who are really high functioning, who are smart, because you can think of a beautiful mind, right? If you need something to hang on to for schizophrenia, hang on to that movie, A Beautiful Mind, and recognize that John Nash is brilliant. He is a brilliant scientist who also happened to have schizophrenia. So it doesn't necessarily wreck somebody's brain, right? And his son is a brilliant mathematician who also has schizophrenia. So just know that sometimes CBT and mindfulness, recognizing Okay, this is that voice. It's telling me something. I'm going to listen to it. I'm going to see what it has to say. You know, like starting to pay attention to the voice, the auditory hallucination, and maybe being able to find a way to live with it or work with it. That's sort of the focus a lot of times of mindfulness interventions with schizophrenia. So we'll move on. Bipolar and related disorders. So the thing to know about bipolar, and I like drilled this into my abnormal classes head, moodiness is not bipolar disorder. People who have angry outbursts, that's not bipolar disorder. People call it bipolar disorder all the time. You are so bipolar. I wish you would stop being so bipolar, right? We hear that a lot. It is not bipolar disorder. Bipolar disorder requires distinct periods, a departure from baseline level of functioning. For mania or hypomania, right? Hypomania is just less mania, not quite all the symptoms for mania, and depression or dysthymia, right? But you have to have that departure from normal, and it has to be cyclical. You have to be able to see those cycles. There is what's called rapid cycling, and I've heard people say to me, I have rapid cycling bipolar disorder. I probably cycle 5 or 6 times in a day. That's moodiness. That's mood dysregulation, but that's not rapid cycling. Rapid cycling is like a few days at a time, okay? So you can remember bipolar 1 is the number 1 most severe, right? I try to help you remember the little things that help me. Bipolar 2, which requires hypermania and depression. Hypomania, it's slightly milder. And then cyclothymia is hypomania and dysthymia. It's chronic. So C, chronic, C, cyclothymic. So that's how you can remember that, right? So cyclothymic is sort of, instead of having huge waves like Lord Byron, the poet, who had huge bipolar disorder, or Edgar Allan Poe, or Virginia Woolf, you have more sort of smaller departures in cyclothymia. Okay. For bipolar, the treatment of choice is the first line is medication, mood stabilizers. Lithium is a mood stabilizer. Lithium is not used as the first line now. It's sort of the last line because the side effects are really powerful, and also it has really high toxicity, and so it has to be monitored very closely, right? You can get to a toxic dose quickly, huh?
That was on the quiz.
That's it?
Well, it asked about, it was talking about treatment, so which one of the things is toxicity?
Yes. Toxicity is where, so you have what's called an effective dose, right? So an effective dose is where you see a reduction in symptoms. And then you have a lethal dose, which is obviously lethal, right? And the closer the effective dose is to the lethal dose, the more closely you have to monitor it. And it gets real complicated in med monitoring because things like smoking change the way your body takes in medications. So like with antipsychotic medications, if somebody is a smoker, then you have to titrate their medication level. If they quit smoking all of a sudden, then that messes with their body chemistry, and then you have to titrate differently, right? And so the reason lithium isn't our first line anymore is because the effective dose and the lethal dose can be pretty close together. But it is a stabilizer. The reason medication compliance is really hard with bipolar is what? Abnormal people. Why do people not want to take their medication on bipolar disorder? They love the high, right? Mania is a natural high. It's like cocaine or something else, right? It impacts your dopamine receptors. It is a high that people don't want to give up. People are very reluctant to give that up. If you want to know more, I'm going to try to go through and plug in a whole bunch of different talks and things that are illustrative for this. But Kay Redfield Jamison is a brilliant researcher and writer about bipolar disorder and has written like a book called Touched with Fire, which goes through and looks at a bunch of historical figures, artists particularly, musicians and writers and painters and people like that, and looks at sort of a psychological autopsy and sees whether she thinks that they have bipolar disorder, and they seem to go pretty closely hand in hand. Yeah?
This is
Oh, yeah, yeah.
Because, those three being sleeping, but what causes them to have depressive episodes versus schizophrenia to stay high in potency?
So there's a shade of distinction here, okay? And so the difference is schizophrenia includes delusions and hallucinations, and I think that's what you're talking about, right? Sort of magical thinking or belief in. But schizophrenia doesn't necessarily include a high mood level. So when we talk about mania, we talk about a reduced need for sleep, grandiosity in ideas, fast flight of ideas. You can't keep that thoughts in your head for any length of time. We see really, really engaging in risky behaviors, but it's a result of sort of a hyperactive drive that is difficult to draw back down, right? So with schizophrenia, those hallucinations and delusions are not accompanied. They're not typically accompanied by that rapid thinking and that reduced need for sleep and all of those other things that are associated with mania. You can have psychotic features in a depressive episode. You can have psychotic depression where you see or hear things that other people don't see or hear, but it's associated. It is exclusively contained within a depressive episode. Or you can have that as associated, delusions or hallucinations as associated with a manic episode. So Kay Redfield Jamison talks about when